Hello and welcome to the topic conversion disorder in the psychiatry module. By the end of this topic, you should be able to define conversion disorder, discuss the pathophysiology and risk factors associated with conversion disorder, describe the clinical manifestations of conversion disorder, and finally discuss the management approach to conversion disorder. Let's get started. Conversion disorder, also known as functional neurological symptom disorder, occurs when a person experiences neurological symptoms, which are symptoms of the nervous system, which are not attributable to any medical condition. Conversion symptoms suggest a physical disorder but are the result of psychological factors. According to the psychodynamic model, the symptoms are a consequence of emotional conflict with the repression of conflict into the unconscious. In the late 1800s, Freud and Breuer suggested that hysterical symptoms resulted from the intrusion of memories connected to physical trauma into the somatic innervation. This mind-to-body process was referred to as conversion. The patient has been postulated to derive primary and secondary gain. With primary gain, the symptoms allow the patient to express the conflict that has been suppressed unconsciously. With secondary gain, the symptoms allow the patient to avoid unpleasant situations or garner support from friends, family, and the medical system that would otherwise be unobtainable. According to sociocultural theories, the direct expression of emotions is impermissible and somatization takes its place. So what are the usual underlying causes or risk factors in patients with conversion disorder? Well, conversion episodes are nearly always triggered by an overwhelming stressful event, an emotional issue, or a mental health disorder such as depression. Although there may be no medical or physical cause found to explain the symptoms, they are real to the person who is experiencing them. Conversion disorder can present with motor or sensory symptoms including any of the following: motor symptoms or deficits, impairment, coordination or balance, weakness, paralysis of the limb or the entire body, impairment or loss of speech. The clinical manifestations of conversion disorder include weakness, movement problems such as tremors or twitching, sensory issues such as loss of sense of smell or touch, and presyncopal attacks. People with conversion disorder may also experience blindness, diplopia, weakness or paralysis, muscular spasms, worst case seizures, loss of balance, incoordination or ataxia, numbness, memory loss, deafness, difficulty swallowing, inability to speak or known as aphonia, loss of sense of smell or anosmia, motor tics, and even hallucinations. So symptoms may begin without warning and can be debilitating. Episodes are typically short in duration, usually lasting days or weeks, though this can vary from person to person. The DSM-5 criteria suggests the diagnosis is based on these criteria, which are as follows: one or more symptoms of altered voluntary motor or sensory function. Physical findings provide evidence of incompatibility between the symptom and the recognized neurological or medical conditions. The symptom or deficit is not better explained by another medical or mental disorder. The symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning or warrants medical evaluation. So specific symptom types which have been described before include weakness, abnormal movements, dysphagia, dysphonia, seizures, as well as anesthesia. Assessment of mental status during examination is paramount. The following mental status examination focuses only on the possible presentation of a patient with conversion symptoms. So in a clinical setting, one would likely see the comorbid psychiatric presentations as well. And this may be hard to distinguish and separate from conversion symptoms. So let's take a look at the mental status examination. The appearance: usually the patient would be normally dressed with appropriate eye contact and normal hygiene. As for the gait, it may be normal or ataxic. Some types of psychogenic paresis or pseudochorea or aesthesia abasia pattern of gait may be seen. The attitude would be appropriate. The behavior could be preoccupied with symptoms, or the patient could be just indifferent. Patient would have a normal speech or may have evidence of the conversion disorder such as aphonia or dysphonia. Attention and concentration may be decreased due to the preoccupation with symptoms. The memory may be normal or impaired. Orientation-wise, likely the patient would be oriented to person, place and time. And as for the mood, perhaps they could be anxious about the condition or probably indifferent about it. As for the effect, it could be restricted, labile, or the mood could be incongruent. For the thought process, this could also vary from concrete and perservative to normal, or an obsessive component may also be present. The patient would not likely be suicidal or homicidal unless comorbid conditions are present together. There could be possible hallucinations, as the patient usually retains some insight that these are not real, and the conversion hallucinations are often involving multiple modalities such as verbal, tactile, and visual, apart from just auditory hallucinations. Diagnosis is made by a psychiatrist based on the history of the affected person's symptoms, as well as a discussion about their lives and feelings. It can be difficult to diagnose conversion disorder, and multiple tests are often performed to exclude other causes of the symptoms. So the diagnosis is usually reached by the process of elimination or exclusion. The presence of physical symptoms that would need to involve multiple parts of the nervous system. Assessment revealing that a person's responses differ from those typically associated with neurological conditions, and when no physical cause can be found for the symptoms, there is no cause of stress, a diagnosis of conversion disorder may be achieved. There are certain principles that are used during the neurological examination, and this is to distinguish psychogenic deficits from neurologic ones. The pattern of deficits usually do not conform to known anatomical pathways. For example, patients who present with monoparesis do not have weakness in a corticospinal tract or neuropathic or myopathic distribution. In addition, no changes may be seen in reflexes or tone that typically would be expected in the examination. Patients with conversion disorder may present with neurological symptoms such as hemiparesis, paraparesis, or monoparesis. As for weakness, they could have altered consciousness, visual loss or seizure-like activity, bizarre movement disorder, lack of coordination, as mentioned earlier, aphonia or dysphonia, abnormal gait disturbances, and also a probable pseudocoma. Neuropsychological testing shows evidence of impaired attention and short memory span. Lab tests for psychogenic movement disorders include the following: serum lactic acid, which is done in the event one suspects patients to be having seizures. In pseudoseizures, the lactic acid levels are normal. 24-hour urine studies for copper, serum ceruloplasmin, and slit lamp examination for evidence of Kaeser-Fleischer rings are carried out to look for evidence of Wilson's disease. Thyroid-stimulating hormones, erythrocyte sedimentation rate, and other autoimmune studies, HIV antibodies, Lyme antibodies, anti-streptolysin O antibodies, human chorionic gonadotrophins, urine and serum toxic screen for stimulant or illicit drug use, as well as other drug levels such as anticonvulsants and digoxin levels to look at presence of toxicity. As for imaging studies, the MRI of the brain with diffusion-weighted imaging, including the cervical region, is also done. This is to exclude pathologies such as multiple sclerosis or any other demyelinating diseases or axonal neuropathy. For pseudoseizures or PNES, the investigations may include EEG, which is an electroencephalography, echocardiogram, as well as Holter monitoring to exclude any cardiac causes of the neurological deficits that they present with. The current understanding of the phenomenon of conversion disorder implicates some role of the unconscious in the pathophysiology of this condition. So many patients who experience a conversion disorder are unable to understand this inner conflict, which is perhaps occurring on a subconscious level. They may achieve resolution of the conflict as well as their physical symptoms once they are gently made aware of this connection. Once the patient is aware of this, the psychological currency of the symptom loses value and the symptom may be allowed to improve. So the best evidence for the treatment of conversion disorder is with cognitive behavioral therapy. Sometimes medications are also used and have been tried with success, includes tricyclic antidepressants and haloperidol as well. Electroconvulsive therapy or ECT is considered for coexisting psychological or psychiatric diseases together with conversion disorder. To summarize, conversion disorder, also known as functional neurological symptom disorder, occurs when a person experiences neurological symptoms which are not attributable to any medical condition. Conversion episodes are nearly always triggered by an overwhelmingly stressful event, an emotional issue, or a mental health disorder such as depression. Although there may be no medical or physical cause found to explain the symptoms, they are real to the person who is experiencing them. Patients with conversion disorder may present with neurological symptoms, and the common ones include hemiparesis, paraparesis, monoparesis, altered consciousness, visual loss, or probably seizure-like activities as well. Investigations are aimed at excluding a neurological disease or condition, and the first line of management is psychotherapy in specific cognitive behavioral therapy. Medications can be used to assist with therapy, which include antidepressants as well. We have come to the end of this topic. Thank you for your time.